All right, you've made it to resuscitation model number 4. In this resuscitation module, we're going to talk about the approach to hemorrhage. Sherry Shabowski here again, ready to go. All right, there are 3 components in the approach to hemorrhage. In all patients with hemorrhage, time is of the essence. You need immediate evaluation and routine assessment of all 3 components to avoid a negative outcome. If you don't, you might find yourself in this position behind the 8 ball. And your patient might find themselves in a worse position. That is, they're about to take the ultimate dirt nap. I thank Chris Ross for this reference. I wish I would have thought of it myself, but he's the one who gave me this one. All right, approach to hemorrhage. 3 components. Proximal control, replace the losses, correct the coagulopathy. When you're treating someone with hemorrhage, you can be treating any of the 3 components. Sometimes you're treating just one of the 3, sometimes a combination of 2, sometimes it's a combination of all 3, such as in the case of a massive bleeding varicose bleeder. They can have a coagulopathy in addition to needing proximal control and blood replacement. So when you approach your patients, just like the severe respiratory distress patients, you're going to ask yourself 3 important questions. The first one is, can you gain proximal control? And by that I actually mean you. Such as if someone had intra-abdominal bleeding, such as in the case of someone who had a ruptured ectopic pregnancy, what would you do to gain proximal control? Well, I guess you could cross-clamp the aorta, but that's typically not the best option for a young lady with an ectopic pregnancy. What if you have somebody who's got a head bleed? Should you obstruct carotid flow bilaterally in order to stop the bleeding? Remember, our goal is to do no harm. What you need to do is determine immediately if you yourself are able to gain proximal control. And when that's not the case, you should immediately consult the service who can and get them on the way in. So proximal control, review, do it yourself if you can, consult the proper surgical service if you can't, and never underestimate the role of interventional radiology. In these cases, you need to consult them early. They are rarely rating an angio for you to call. All right, question number 2. How will you replace the losses? Replacing the losses is fluid with fluid, blood with blood, cross-matched whenever possible. Type-specific will be the next best thing. For emergent transfusions, such as massive uncontrolled bleeding, hemorrhage with shock, profound anemia with ongoing losses, or anemia associated with myocardial ischemia, you gotta give them the O. O negative for younger females and O positive for men and women beyond childbearing years. Order it up early, get it going. Oxygen delivery, again, is essential to life. Oxygen delivery is oxygen saturation times hemoglobin times cardiac output. Cardiac output is a function of heart rate and stroke volume is a function of preload and pump function. In patients with shock, you want to supplement oxygen. You want to maximize preload with IV fluid or packed red blood cells, depending on the hemoglobin. Rhythm extremes can be detrimental, so you want to treat those. And ionotropes might be necessary, but again, never given without filling the tank first. How does hemoglobin affect oxygen delivery? It's different in different people. In a younger person, through a wide range of hemoglobins, from 15 all the way down to less than 7, you get 100% oxygen delivery. You're doing just fine, no matter how low it gets within that range. But after it gets to the critical point, which people use an estimate of 7, it may be as low as 6, you start to have a decrease in oxygen delivery. In elderly people or people with high demand, or people who have compromised coronary arteries or other illnesses, they're going to start to decrease oxygen delivery at a much higher hemoglobin. All right, pop quiz, hotshot. If a patient is hemorrhaging with a hemoglobin of 6 and you give them 2 liters of normal saline, what will the repeat hemoglobin be in grams per deciliters? And how will this affect oxygen delivery? Well, aggressive fluid resuscitation and hemorrhage further decreases oxygen delivery by decreasing the concentration of hemoglobin in the circulation. In the case I gave you, the hemoglobin around the repeat would probably be 5. If you give aggressive fluid resuscitation to patients with a hemorrhage, especially if a vessel is wide open, all it does actually is increase the pressure gradient across damaged vessels, sending more blood out the hole. Blood loss increases and oxygen delivery is compromised further. So maybe you should approach them Cincinnati style. It was the people in Cincinnati who do trauma there who first published papers regarding this no fluid resuscitation for patients who are bleeding. What their proposal was is that you should immediately stop the bleeding, gain proximal control, and then resuscitate the patients because you did not want to blow more fluid out the blowhole. It's a good idea. It's awesome, especially if you can clamp the vessel immediately or treat the problem immediately. In that case, it makes sense because proximal control should always come first whenever that can happen. But it can't always happen. Sometimes that requires an operation. Getting a patient to the OR may take a lot of time. You can't leave them without any fluid or volume resuscitation as they continue to bleed out while you're waiting to gain proximal control. So that actually only makes sense when you can immediately gain proximal control. On the other hand, I agree that you don't want to give them so much fluid that you increase the losses through the hole and potentially increase the hole by pushing pressure across it. So best practice would be to prepare to gain proximal control immediately, be judicious with fluids, and get blood products immediately to replace blood loss. Don't forget, you always replace blood with blood. A common ED blunder would be to give 3 or 4 liters of IV fluid. It's already in and the blood is starting to look like Kool-Aid before you even think about doing the type and cross or call the blood bank. Remember, decide if you can gain proximal control or call someone who can first, then be judicious with fluids and very proactive with transfusions. Get someone working on blood as soon as you recognize a patient with hemorrhage, and blood is replaced with blood. Question number 3. Is there a coagulopathy that needs to be corrected? So you're thinking you're slick. You got an upper GI bleeder, you give them IV fluid, blood transfusion is started quickly, you've emptied the stomach, you've given the meds, GI's on the way, you are doing good. But now you recognize that you're on your 4th unit of packed red blood cells and the patient is still bleeding. A lot. When you recognize that you didn't send the coags. So, INR 2.9. This is the one that sneaks up on you and bites you in the ass. Do you remember what the second letter in FFP stands for? Yes, my friends, that's frozen. And if you don't recognize that you might need FFP and you call for it in a desperate circumstance after you've waited a very long time and transfused and transfused and transfused, you're still going to have to wait until they thaw it. Huge blunder. So this is why question number 3 should always be addressed in patients who are hemorrhaging immediately. Questions should be addressed in order immediately. Is there a coagulopathy that needs to be corrected? So how do you correct the coagulopathy? Well, in the case of hepatic coagulopathy, you give FFP and vitamin K. Thrombocytopenia and aspirin induced requires platelets. You have to replace factor with factor. If you don't know the right factor, you can consider recombinant 7A, but only in the most extreme circumstances because it actually can cause clotting and put you in a more difficult position. You can also use cryoprecipitate or FFP, but only if you absolutely need to start something immediately because the percentage of factor is low in both. And if you were to replace someone who actually has a factor deficiency with FFP, you could literally drown them with FFP before you even make a dent in their coagulopathy or reversing their factor. Iatrogenic anticoagulation with Coumadin also exists, and for that you'll also give FFP and vitamin K. But it kind of behooves you to stop and think about it. Who are the iatrogenically anticoagulated? If you are presenting your patient or thinking about it yourself and recognize they have a heart valve, DVT or PE in the past, cardiomyopathy, AFib, atrial stents, all these people are likely to be on Coumadin and likely to be anticoagulated. So you might want to check that coag straight off the bat. And don't forget that there is a subset of patients who are receiving polypharmacy for anticoagulation. In the dying, there's an easy answer when you find someone who's coagulopathic. Of course, you reverse them. But what about those people who are hemorrhaging and they're in danger? They're typically anticoagulated for a reason, so you're going to have to do a risk-benefit assessment for clinical decision-making before you reverse the patient, unless it's a dire emergency. You might want to think of these questions. How would transient reversal affect the disease process? What if they developed a clot? How likely are they to develop a clot in the short run? How likely is the patient to suffer ill effects from the blood loss if you don't? Can you get proximal control without reversing the anticoagulation? These are all important questions to consider in the patients who you're thinking about reversing. Now remember, the rule of 3 in hemorrhage. First, proximal control. Do it yourself or get someone who can. 2, replace the losses and do no harm while you're replacing them. Correct the coagulopathy. You can't correct it if you don't consider it. And never forget that poly anticoagulation exists. All right, be careful out there.